So, Assalamu alaikum. I welcome you all to the infectious disease session at the Shaukat Khanum Symposium. And we are very privileged to have three speakers with us today who actually don't need any introduction, but we are very proud to have them here joining us at the 21st Shaukat Khanum Cancer Symposium. So we have three talks lined up. Can we have the program online? So if you have a look, so we have Dr. Altaf Ahmed. Dr. Altaf Ahmed needs no introduction. He's the consultant infectious disease and microbiology at the Pakistan Kidney Liver Institute and Research Center. And he will be giving us a talk on antimicrobial resistance. Then this will be followed by Dr. Gökhan Metin, who's actually joining us from Turkey. We have a recorded version of his talk, but he will hopefully be joining us for the live question and answer session. And then we have Dr. Naseem. Dr. Naseem also needs no introduction. She's literally the godmother of infectious disease in Pakistan. And she has inspired generation of doctors to become associated with this specialty. And she'll be talking to us about drug-resistant tuberculosis. So our first speaker, Dr. Altaf, I take the privilege to invite you to the podium for your first talk. So please join us.
Sunday. Think so. So thank you, Somaya. It's always a privilege to be associated with Shaukat Khanum, no matter which way. There's a lot of respect for this hospital. So can't miss this opportunity to talk about it. So preventing infection and antibiotic resistance. So two jobs, but obviously they are interrelated. So, right. So congratulations for coming to the semi-final of T20 World Cup. So I was just waiting for the final shot. That why I was a bit late. Yeah. So I'm from Pakistan Kidney and Liver Institute and Research Center, which is doing transplant for liver, kidney, and now bone marrow. But I have advised them to do something for brain transplant as well, because we need it very badly. This presentation is about challenges and solutions. So, मुझे तो यही समझ आता है. So many challenges, उसका solution देना है. But 20 slides on challenges and about 60 slides for solution. So I can justify my talk over that. So challenge. Infections are leading cause of morbidity, mortality. In the middle, it can cause pain, suffering, and offer permanent discarding, which we forget. We always talk about a lot of resistance and that's it. But what that resistance has to do with the patients, prolonged hospital stays impact on cost, or हमारे मुल्क में is terrible. This is Fatima, a 15-year-old child who had a fracture on right elbow, came to a local hospital, and then after 2 weeks, leaving the hospital, she had pain and pus coming out from the wound after surgery. So she's living in a village 6 hours away with her mother and two younger sisters. वो उनको लेकर आए. The doctor ने कहा it's not a surgical site infection because obviously you can dig out the gaps from this story. So what is happening? He doesn't know what is SSI. So 2 weeks after discharge and said it's not SSI. Again, huge swelling, उसने antibiotic दे दी. Again, which antibiotic? Where is the culture? 2 weeks later, he noticed huge swelling in arms, drowsiness, loss of consciousness. Dobara, I went straight to the ICU because she was very, very sick. And for a month, she stayed there. Fortunately, she survived with the deformity of her arm. And of course, she says that now my friend in the school is the one who do the homework for me. And I always notice pain and worries in the eyes of my mother. And this is an ongoing story. So this impact, we don't know because the moment patient leave the hospital, we forget about it. We don't know what's going to happen, which person. But global death from bacterial antimicrobial resistance in 2019 is horrendous. And just after all parts of Africa, South Asia comes with India, Pakistan, and Bangladesh. And we are on top of everyone else except Africa. So, what are we doing wrong and why? Looking for new antibiotics? It's not easily available. And if available, you cannot afford it. How can you afford ceftazidime, avibactam? I know people cannot. So, लोग कहते हैं एंटीबायोटिक आ जाएगी कब आ जाएगी एंटीफंगल तो मिलती नहीं है यहाँ पे इतनी मुश्किलों से वी ऑलवेज टॉक अबाउट कि ये अवेलेबल है कराची में ये अवेलेबल है लाहौर में एंड अगर मिल भी जाए तो कौन अफोर्ड करता है सो प्रॉब्लम इज टू मच हेल्थ केयर एसोसिएटेड इन्फेक्शंस is I mean surveillance data is missing from Pakistan but is many times higher than the Western world. And a lot of patients are dying, and we are losing patients because of this. For example, this one doctor caused eye infections, not keeping his hand hygiene intact. 126 people were infected. And these stories like these goes on and on and on. This is a American Journal of Infection Control paper from Pakistan. And the surgical site infection rate is quoted 40%, which is, you can think about what can happen with 40% of SSI. Blood is steam infection, lower respiratory tract, neonatal infection is sky high. It's beyond any target. There is another challenge of emerging disease, and we are all witness to it. और इसके साथ जो हमें problem हुई है, we all know that. So these diseases will keep on coming. The reason is lack of one health. अभी तो ये concept शुरू हुआ है. It's just emerging now, and people are started working on it. But क्या होगा, कैसे होगा, we don't know. We are stuck here with the basics, water, sanitation, and hygiene. जब हमें इसी से problem है, so what can we talk about other emerging diseases? यही हमारा problem है. We have been talking with Dr. Naseem and I have been talking about this long time कि जब तक ये ठीक नहीं होगा, nothing will happen. And as a result, what happens? Hyderabad, Lahore, Karachi, you name it. Typhoid, superbug, is spreading like anything. Is XDR typhoid, and all the ID and micro people knows it started from Hyderabad. Generations of generations. I read about it in MBBS about TB, typhoid, and malaria, and still people are reading about a worst form of TB. Dr. Naseem is going to talk about it. Worst form of typhoid and malaria and diarrhea and other infectious diseases. It has been generations. So it's not AMR is just a simple problem. It affects every stage of life. And this famous diagram tells you what is going to happen in future. We know the future, unfortunately, but we are not doing much about it. Misuse, abuse, or overuse. As per today, it's happening everywhere. 221 पाकिस्तानी 2021 में पाकिस्तान ने 120 अरब की एंटीबायोटिक इस्तेमाल की and so much money is wasted in antibiotics. इसके अलावा चारा क्या है? How would you control AMR? Controlling AMR in hospital is not enough. This famous diagram, Pakistan is one of the most biggest users of carbapenems. And as a result, you can see the data of carbapenem resistance and E. coli now I think is much more than 19%. coming to 30% now. So talking about carbapenem sparing agent and what to do with carbapenem, you don't have any choice. Now you have the target of doing fancy things, organ transplants. 50 lakh में liver का transplant होता है, kidney transplant 30 lakh, and so on. And one infection and you are gone, lose the patient. कितना बड़ा risk है? How are you going to control all this? So 20 slides हो गई, now solution. कैसे होगा? जब तक हम ये तीनों चीजों को नहीं करेंगे, in isolation, solo effort, it will not going to work. You have to combine IPC, antibiotic stewardship, and diagnostic stewardship together. Doing one thing is not going to solve the problem. And this is happening, and I've been writing to government about this off and on. So together we can make a difference. Otherwise, make a difference little bit, not much. All these studies, these reviews tells you very clearly that a lot of things happens if ASP is included with infection IPC. Similarly, in this literature also, there are plenty of them, that ASP alone is not going to work. That's the message. And hand hygiene, of course, is one of the biggest steps. So this paper tells you about the integrated approach, very nice publication. Tells you about the integrated stewardship model, which is antimicrobial infection control and diagnostics. So we recently celebrated the future is infection prevention, but the future starts from here. We still don't know what is the hierarchy of IPC measures. It's always stressing on the inverted pyramid, the tip of this inverted, forgetting all these things together. That's why in most of the hospitals, it's not really working. Misconception, there's a lot of it. And alcohol hand rub is haram. That starts with that. Recently, in an endoscopic unit, a consultant mentioned that when you dry the endoscope after washing, you put alcohol in it. And he said, no, don't use it because it goes into the stomach. So that kind of concept, it's amazing. Nurses are only responsible for infection control. Hand sanitizer is good for everything. And gloves will save me, and scrub suits don't spread germs. Canteen में भी पहनो, मस्जिद में भी पहनो. एक ICN रख लो 500 बेड के हॉस्पिटल में, that is enough. Needle को काटो, काटते क्यों नहीं हो? So on. So आखिर में मुझे कहते हैं इतने घबराने की क्या बात है? So घबराने की तो बात है, because we don't have that much antibiotic. So concept, the solution is लोगों के concept तो ठीक करो, behavioral science पे काम करो. Otherwise they will not accept your effort. It took many years कि जो मेरी team है वहाँ पे, so PKLI के employees now they accept it. Still occasionally ऐसे लोग आ जाते हैं. The reason is ये जो concept है ICNs, it has to go. It must be IP, infection preventionist, and all these people work for infection prevention, not nurses. This is the problem with us. जब मैंने PKLI में I said I want an infection preventionist, he said no, you won't get it. You can get ICNs. So this is the problem of century-old problem. It's 1863-47. Come on, 2022 चल रहा है. You cannot work IPs just like that. So we have to change. एक solution ये है. Change your team. IPC is possible. जिन लोगों ने ये किया है, उन्होंने teaching and training पे बहुत जोर दिया, and it works. Teaching and training is the main armamentarium, I will say. Start with the housekeeping department, the worst and the most neglected part in any hospital. इन बेचारों का ये काम है कि डीन और एमडी के ऑफिस की सफाई करो, बाकी छोड़ दो. This is the reason teaching and training, impact of staff education, AQH, a hospital study long time ago, but look at the impact of episodes in WAP. It's tremendous. It works. It always works. You can do that. You can do it in your own hospital. इफ यू वांट टू नो वेयर डू यू स्टैंड, किधर खड़े हो, सब ठीक हो रहा है, सब तो ठीक हो रहा है, गलत किधर हो रहा है? गलत ये हो रहा है कि यू डोंट नो वेयर डू यू स्टैंड। दिस इज अ वेरी वंडरफुल टूल, मैंने इसको यूज किया है। ये WHO का टूल है, इट कंसिस्ट ऑफ 8 core components and 81 indicators is screen out all the system in your hospital और आपको बताता है कि where do you stand. You must go for this tool to know where your hospital stands. साउथ पंजाब में मैंने एक स्टडी की थी 2021 में, and this was the result of all these hospitals including PKLI, Children Hospital, DHQ, Muzaffarabad, Muspan, and they are right at the very basic. कुछ भी नहीं था इनके पास, but they all had one thing, सबके पास गाइडलाइंस थी। So doesn't matter कितनी, आप गूगल से डाउनलोड कर लो, आईपीसी की गाइडलाइंस, हैंड वॉशिंग हर जगह एक ही होगी, हैंड सैनिटाइजेशन की बात होगी, सबकी बात होगी। दे ऑल हैड गाइडलाइंस, द प्रॉब्लम इज इम्प्लीमेंटेशन। एजुकेशन भी हो जाएगी, सब कुछ होगा, इम्प्लीमेंटेशन कैसे होगी? सर्वेलेंस में दे आर वीक, सो इट आइडेंटिफाइज योर सेटअप वेरी वेल, स्क्रीन आउट एवरीथिंग, एंड अगेन इम्प्लीमेंटेशन इज द की। लोग कहते हैं हमने ये बना लिया, हमने ये गाइडलाइंस बना ली। द फर्स्ट थिंग आई वाज टोल्ड in Karachi, in Indus, to make a guidelines. I said, guidelines तो बन जाएंगी, then what? So implementation has to be there and it needs administrative support. Without it, कुछ नहीं हो सकता. People will be suffering. Basic guidelines है WHO की, and you can talk about CDC and all those international societies की guidelines है, कोई कमी नहीं है. The problem is in implementation. अब तो हमारे पास ऐप भी है, हमारे पास नेशनल गाइडलाइंस भी है, पढ़ता कौन है? और अगर पढ़ते नहीं है तो अप्लाई कैसे करेंगे? इवन ऐप हैज मेक लाइफ सो सिंपल, इसको पढ़ के हैंड वॉशिंग तो फिर भी करना पड़ेगा ना। सो दैट इज द रीजन के इम्प्लीमेंटेशन। अब इम्प्लीमेंटेशन करते हैं और नहीं करते, बट दे फॉरगेट अबाउट दीज प्रैक्टिसेस and then they don't do this, और unnecessary चीजों में पैसे जाया करते हैं। and we have seen many examples, and one of the example is this, कि लोग अपने जूते को बचाने के लिए सीढ़ियों पे कैफेटेरिया में पहन के जा रहे हैं, मरीज भी पहन के जा रहा है, कोई सर पे पहन रहा है, कोई जूते में पहन रहा है। so they are happy about it कि हमने बचा लिया अपने आप को, but this is the concept going on. Hospital design improvement कोई नहीं है, जिसने जो चीज बनाई, जो शॉपिंग मॉल बना रहा है वही हॉस्पिटल बना रहा है। दे हैव नो आइडिया कि हॉस्पिटल कैसे बनता है। इन दीज काइंड ऑफ हॉस्पिटल जो इंडस्ट्रियलाइज्ड एरा में होता था, इट्स नॉट पॉसिबल टू डू एनी आईपीसी एक्टिविटी और एएस एक्टिविटी। दीज थिंग्स शुड नॉट बी अलाउड, लेकिन हमारे इंजीनियर्स को समझ नहीं आता। दे स्पेंड अ लॉट ऑफ मनी इन टाइल्स, false ceilings, growing fungus, and there has been so many cases of fungal spread through these. और इंजीनियरिंग सिस्टम पे या इंजीनियर्स को बुला के कोई मीटिंग करो तो इंतजामिया को बहुत बुरा लगता है कि आईपीसी वाले अब इंजीनियरिंग डिपार्टमेंट में क्या करने गए। सो फंगस ग्रोइंग और इन इम्यूनो कॉम्प्रोमाइज पेशेंट्स सेटअप, यू कैन थिंक कितना बड़ा प्रॉब्लम है ये। सो ठीक है, इन चीज़ों में पैसे लगता है। वी आर फॉर्चुनेट कि हमारे पास सिंगल बेड आईसीयूज हैं और वार्ड्स हैं, सिंगल बेड, नॉट वो उस तरह का, बट वी आर फॉर्चुनेट। दैट्स व्हाई आवर इन्फेक्शन एसएसआई रेट इन किडनी ट्रांसप्लांट इज 1% एंड लीवर ट्रांसप्लांट इज 5% मैक्स। सो ये नहीं कि हमारे लोग गलत काम नहीं करते, बहुत सारे करते हैं गलत काम, स्टिल वी आर केपेबल टू कीप इट टू द मिनिमम। हाई टच सरफेस, there's a lot of studies, ये हमें करना पड़ेगा। अगर आपको आईपीसी करना है तो ये आपको करना पड़ेगा, सिर्फ वॉशिंग हैंड्स से काम नहीं चलेगा। यू गॉट टू क्लीन द एनवायरनमेंट थॉरली, क्योंकि दीज आर दी प्लेसेस जहाँ से जर्म्स ट्रांसफर होते हैं। सो सर्वेलेंस का तो कोई नाम ही ना ले, कि बिल्कुल मतलब दिस इज नोबडी नोज। डाटा आप मांग लें तो बहुत सबको परेशानी शुरू हो जाती है, बट दिस इज रिक्वायर्ड। लोग करते हैं, कुछ जो बड़े प्राइवेट इदारे हैं इंक्लूडिंग PKLI, लेकिन मैं एक जनरल बात कर रहा हूँ बाकी अस्पतालों का। तो जो भी डेटा पाकिस्तान से निकलेगा वो इज नॉट रियली रिप्रेजेंटिंग पाकिस्तान। बेंचमार्क कोई नहीं है, WHO का या CDC का बेंचमार्क लेते हैं, हमारा अपना कोई बेंचमार्क नहीं है कि व्हाट इज द लिमिट कि जिसको हम क्रॉस करें तो इट शुड बी अलाउइंग टू बीट एंटीबायोटिक रेजिस्टेंस पे आ जाता है इन्फेक्शन कंट्रोल के बाद। सबको पता है इसकी डेफिनेशन क्या है, बस इसको पढ़ना बड़ा आसान है लेकिन करना बहुत मुश्किल है। एक ये स्टडी हुई थी जिसमें डॉक्टर नसीम है, डॉक्टर समरीन वगैरह अभी पब्लिश हुई है और शेयर हुई है। 67% of the patient receive one antimicrobial agent and most common indication was surgical prophylaxis. 40% उन अस्पतालों में जहां ID और माइक्रो है, जहां पे कोई डिसिप्लिन है, जहां मैनेजमेंट है। What about the government hospital? So this is not 67%, this is 100% patient are on antibiotics. Reasons मुख्तलिफ हैं, but this reason is very common in all over Pakistan. ये पूरे पाकिस्तान को रिप्रेजेंट करता है ये स्टडी। ये एक स्टडी मैंने अभी की है, गॉन फॉर पब्लिकेशन। इसमें 10 कंट्रीज की स्टूवर्डशिप प्रोग्राम को देखा गया, व्हाट आर द गैप्स एंड अपॉर्चुनिटीज। बड़े सारे क्वेश्चंस थे और बहुत सारी चीज़ें पूछी गई थी। सो अगेन प्रॉब्लम वाज लीडरशिप स्टेटमेंट्स एंड टू सपोर्ट AMS, इसका बजट क्या है? मैंने कई जगह से पूछा है इंक्लूडिंग माय ओन हॉस्पिटल, AMS और IPC का बजट कितना है? कहते इसका क्या बजट होता है? इसका तो कोई बजट नहीं होता। सो अगर बजट नहीं होगा तो आगे काम कैसे होगा? सो दैट शोज द कमिटमेंट ऑफ द एडमिनिस्ट्रेशन एंड नो बजट डाउन द लाइन। दिस वाज वन ऑफ द बिग प्रॉब्लम। ASP शुड बी अ डिपार्टमेंट नाउ इंक्लूडिंग एवरीथिंग हियर। अगर कोई चीज ऐसी है जो गलत है तो आप मुझे बता दें। इट शुड वर्क लाइक दैट। अदरवाइज गोल ये होना चाहिए, ये भी होना चाहिए। लुक एट दीज ग्राफ्स, लुक एट द अमाउंट सेव्ड। ये पूरा एक डिपार्टमेंट, एक कमेटी तो खैर है, बट इट शुड वर्क एज ए डिपार्टमेंट ताकि इसकी ASP शुड वर्क लाइक दिस। मेरा ये ओपिनियन है। कोलैटरल डैमेज स्टोरशिप नहीं है तो ये सब कुछ अब आज के दिन हम भुगत रहे हैं। हमारे ID वाले परेशान रहते हैं कैसे ट्रीट करें, एंड दिस इज व्हाट वी हैव जनरेटेड। सो ये किसी और ने नहीं दिया, दिस इज आवर फॉल्ट। नॉलेज ऑफ माइक्रोबायोलॉजी मैं जब भी पूछता हूँ, यहाँ तो लोग काबिल लोग बैठे हुए हैं, आई डोंट चैलेंज देम कि इसका जवाब क्या होगा और इसका जवाब क्या होगा। पूछ लूँ क्या? प्रोटीएस का पूछ लूँ? नहीं, बताओ भाई। कोई बच्चा? बच्चों से पूछते हैं, बड़ों से नहीं। ऑलवेज रेजिस्टेंट टू प्रोटीएस मिराबिलिस इज ऑलवेज रेजिस्टेंट टू। ये बच्चे हो तुम? अच्छा चलो मेरे नजदीक तो बच्चे हो ना। सही। सो और ये जो है ये किस चीज की कहानी कर रहा है? इंट्रिंसिकली रेजिस्टेंट। ये कौन सी ड्रग हो सकती है जो इतनी सारी चीजों से? डू यू एग्री? जो सो कॉल्ड कोलेस्टिन इतनी बड़ी चीज है, तो ये तो बेचारा बहुत सारी जगहों पे, जो अभी बात कर रही थी फुरकाना कि कैसी रिपोर्टिंग होती है, क्या होती है। सो प्रॉब्लम इज दिस, जहां जहां मैंने ये पूछा है, अदर देन ID एंड माइक्रो, सिर्फ 2% को तो पता है ये, क्योंकि मैंने 4th ईयर में पढ़ी थी। प्रोफेसर सलमा इकरम की पब्लिकेशन 3 पेज की, पास भी हो गया था माशाल्लाह से। और अब शायद 3rd ईयर में पढ़ाते हैं माइक्रोबायोलॉजी पैथोलॉजी। सो जब ये नॉलेज नहीं होगी तो फिर आप यू कैन नॉट डू एंटी माइक्रोबियल स्टूवर्डशिप। आप ये समझते हो कि उनको एक एंगल से पढ़ के पॉलिसी बना के, उनको तो नॉलेज ही नहीं है, कुछ पता ही नहीं है। सो दिस इज द फैक्ट कि डॉक्टरों को बिल्कुल बिल्कुल नहीं पता इस चीज का। मेडिकल ऑफिसर से मैंने पूछा, बड़े गुस्से में था ना ये ऐसे स्टेथोस्कोप लगा हुआ जनाब, नया नया, बिल्कुल चमकदार। क्या आप एंटीबायोटिक देते हैं? यस। मैंने कहा एंटीबायोग्राम क्या होता है? 10 नीचे। मैं कहा स्टुअर्डशिप क्या होता है? बिल्कुल ही नीचे। सो आपको पता ही नहीं है आपके डॉक्टर्स किधर हैं, आप इनके साथ। इन द वेस्ट पीपल आर टॉकिंग अबाउट नर्सेस इन एंटीबायोटिक स्टुअर्डशिप, टीम मेंबर, लेकिन हमारे यहाँ तो ये प्रॉब्लम है। सो हमें देखने की जरूरत है कि कैसे होगा, हर एंगल पे काम करने की जरूरत है। वी हैव टू वर्क एवरीवेयर। अब आ जाते हैं डायग्नोस्टिक स्टुअर्डशिप पे। मेरे पास टाइम है? ओके। Challenges for implementation of ASPs in resource limited. One of the challenges laboratory capacity. नहीं हो सकता इसके बगैर, कुछ नहीं हो सकता। ASP इसके बगैर भी नहीं चल सकता, because it's all interrelated. Both are interrelated. ये नहीं होगा अगर आप यहाँ से निकाल दोगे तो कैसे करोगे आप? Just not possible except for few hospitals, maybe 10 in Pakistan, 10 hospitals. क्योंकि अभी तो हमें यही नहीं पता कि वायरस और बैक्टीरिया में फर्क क्या है इसके इन्फेक्शन में क्लिनिकली। कोविड-19 डायग्नोस्टिक स्टुअर्डशिप के बगैर पॉसिबल था ही नहीं। पहले टेस्ट कराओ, बाकी कहानी इन्फेक्शन कंट्रोल, कमरे में बंद कर दो, ये कर दो, वो कर दो, ये दवा देनी, वो दवा। इट ऑल इज, अगर डायग्नोस्टिक नहीं होती तो आप क्या करते? नथिंग। सो सेंचुरी ओल्ड ग्राम स्टेन एंड ये अब नहीं चल सकता। चलता है, इट्स वेरी यूजफुल। 200 रुपए का टेस्ट है, जल्दी मिल जाता है, पॉइंट ऑफ केयर। बट सवाई आईडी और माइक्रो रेजिडेंट डोंट कम टू द लैब कि मुझे रिपोर्ट बता दे ग्राम स्टेन प्लूरल फ्लूइड भेजा था। नो वन, दे वेट फॉर कल्चर एंड सेंसिटिविटी। सो हमें एक ऐसा टेस्ट चाहिए था जिसकी स्पीड, एक्यूरेसी, कॉम्प्रिहेंसिव सब कुछ हो, टर्न टाइम भी कम हो, हैंड्स ऑन टाइम भी हो, फास्ट हो, एक्यूरेट हो, ये हो, वो हो। So microbiology and molecular biologists were working on it since a long time, and we got some innovations in microbiology. अब ये available है लेकिन costly है, it's not cheap, but it is available now. जिनके पास है, they are taking benefit. I mean, this gene expert has revolutionized TB management, and we have got Maldi and Vitek and all those stuff. We are really doing good job for those who are working in a good hospital. So syndromic testing, एक sample से आपको सब कुछ पता चल जाए. So we have got some innovations in microbiology after all. 2 minutes, पहले बताना था. खैर anyway. Film arrays, these are available. So Maldi, it is available. Recently, WHO ने बड़ी मेहरबानी की most wanted deadly fungi की list डाल दी और 7 कैंडिडा ओरिस भी डाल दिया इसमें. Now tell me, कैंडिडा ओरिस जो कि आउटब्रेक पोटेंशियल रखता है, इंट्रिंसिकली रेजिस्टेंट होता है, काफी मुश्किल होती है, इसकी तो डायग्नोसिस में बड़ी प्रॉब्लम है. ये तो डायग्नोस्टिक एक बड़ी लैब भी नहीं कर सकती. सो अगर जो डायग्नोस नहीं होगी तो मैंने इन्फेक्शन प्रिवेंशन क्या करना है और ट्रीटमेंट कैंडिडा स्पीशीज करके निकाल देना है. सो WHO ने तो अच्छा काम किया, बट ओवरऑल प्रॉब्लम है इसके साथ. बिग गैप्स पूरे पाकिस्तान में गवर्नमेंट सेक्टर में. ISO 15189 गवर्नमेंट लैब्स नहीं है, सर्वेलेंस सिस्टम नहीं है, सर्विस सिस्टम फॉर AMR IPC नहीं है. पंजाब में देयर इज नो पोस्ट फॉर ID इन गवर्नमेंट सेक्टर हॉस्पिटल. करेक्ट मी इफ आई एम रॉन्ग. सर्विसेज और पिम्स के अलावा टाइमिंग है 2 बजे तक लैब बंद हो जाती है माइक्रो की. 2 बजे के बाद इन्फेक्शन नहीं होते पंजाब में. रेफर टू प्राइवेट लैब परसेंटेज के लिए, और फिर मशरूम ऑफ प्राइवेट. हर चले जाएं किसी भी गवर्नमेंट हॉस्पिटल के बाहर, सड़क पे खड़े हो जाए, अगर आप वहां पे 5 करोड़ की दुकान ले लें तो बड़ी बात है, नहीं मिलेगी आपको. बिग बिजनेस, बिग गैप्स. जो लैब है, लैक ऑफ सप्लाईज. ब्लड कल्चर की मशीन है लेकिन ब्लड कल्चर की बोतलें नहीं है, गाड़ी है लेकिन पेट्रोल नहीं है. सो ऑल दीज प्रॉब्लम्स आर हैपनिंग. मिसमैनेजमेंट, ह्यूमन रिसोर्स, सब कुछ. Lack of human job of pathologist है, not microbiologist, which is amazing. सो गवर्नमेंट हॉस्पिटल में ऐड जाता है वी नीड पैथोलॉजिस्ट, और उसमें हीमाटोलॉजिस्ट, माइक्रोबायोलॉजिस्ट, हिस्टोपैथोलॉजिस्ट सब अप्लाई करते हैं. सो एक बहुत बड़े हॉस्पिटल में, बड़े शानदार हॉस्पिटल में लाहौर में, उसमें 6 हीमाटोलॉजिस्ट हैं और 1 माइक्रोबायोलॉजिस्ट है, क्योंकि जॉब आई थी पैथोलॉजिस्ट की. तो जो उनको अच्छा लगा उन्होंने रख लिया. नॉट वो 6 पैथोलॉजिस्ट में 4 आराम करते हैं, 2 काम करते हैं, और माइक्रोबायोलॉजिस्ट 1 है, वो अब क्या कर सकता है. सो ये मैंने अभी गवर्नमेंट को बताया कि व्हाट आर यू डूइंग, ये पैथोलॉजिस्ट, व्हाट डू यू मीन बाय पैथोलॉजिस्ट, वो चेंज हो गई दुनिया. सो ऑल दीज प्रॉब्लम्स आर हैपनिंग. सो इसीलिए WHO ने रिसेंटली पॉकेट गाइड फॉर मिनिस्टर्स बनाया, टू कीप द गाइड इन देयर पॉकेट्स. मैं ये समझता हूँ, लेकिन अगर उनके पॉकेट्स खाली हों तो उसमें रख लें, अगर नहीं है तो पता नहीं. सो चाहे वो एग्रीकल्चर वाला हो, चाहे मिनिस्टर ऑफ हेल्थ हो, आई मीन ये अब बताएंगे पॉकेट गाइड रख के कि पॉकेट में रखो और काम करो. सो दिस इज अमेजिंग, बिकॉज वाकई गवर्नमेंट की सपोर्ट हमें चाहिए. सो इट्स अ मल्टी फैक्टोरियल स्ट्रैटेजी, इसके बगैर काम नहीं हो सकता. कोई एक चीज करने से काम नहीं होगा. आखिर में लास्ट मैसेज इज द बटरफ्लाई इफेक्ट. डोंट थिंक, ये एक अमेरिकन मैथमेटिशियन थे एडवर्ड नॉर्टन साहब, उन्होंने कहा कि ए बटरफ्लाई फ्लैपिंग इट्स विंग इन अमेज़न कैन कॉज ए स्टॉर्म इन नॉर्थ अमेरिका. सो अगर लिटिल बिट एफर्ट भी होगी तो कहीं ना कहीं उसका इम्पैक्ट बड़ा होके आएगा. सो एज पार्ट ऑफ इन्फेक्शन एंड हैंड हाइजीन, जो कि मेरा फेवरेट सब्जेक्ट है, Switch program, when implemented alongside IPC in hospital hand, particularly hand hygiene, are the significantly more effective in reducing the development and spread. अगर हम सिर्फ यही चीज फैला दें as a butterfly effect, it is going to help. So again, this slide, get together, we can make a difference, not only one, but the health professional of tomorrow. How do we find among the children of today? तो इनको तो समझा दो, हम तो नहीं समझ सके, शायद ये समझ जाए. So thank you very much, and selfie time. Questions a bit?
Thank you, sir, for the enlightening talk, and it's always a pleasure to hear you speak. We'll have the question and answer session in the end. So now it's time for Dr. Mithan's talk. Dr. Mithan is a professor of infectious diseases at the Hacettepe University in Turkey. And we have his recorded presentation right now, but he will be available for a live question answer session in the end.
Good afternoon. I thought that you will play the previous record that I already sent, but if it will be more practical, I can present it now. This is not the right presentation. I was just waiting for the questions, so I'm very sorry for.
Dr. Mithan, we'll continue with the recorded version of your presentation. We'll have you for the live question answer session then.
Okay, okay.
Good afternoon. My name is Gökhan Meta. I am working as an infectious diseases consultant at Hacettepe University Hospital. And first of all, I want to thank the organizing committee for their kind invitation. These are my disclosures for the last 3 years. And we all know that there's a huge information about the treatment of invasive fungal infections in neutropenic patients. There are many guidelines. There are many recent published papers, but every center is not the same with the other one. So we have different epidemiologic features. We have different background for diagnostics and treatment. In this presentation, I will try to focus on how we brought together all literature, epidemiology, and technical background to build a guideline in our hospital. So management of fungal infections in cancer patients has 4 basic strategies. The first is the prophylaxis, then empirical treatment, diagnostic treatment, and target therapy if we can able to show the etiological agent. Prophylaxis is very important. We know the high rates of mortality and morbidity in leukemia patients or other neutropenic patients for fungal infections. But we should keep in mind that prophylaxis does not only mean the chemoprophylaxis. Environment protection is also as important as chemoprophylaxis to prevent fungal infections. Then see what do we have in our hands as the chemoprophylaxis. We have high-grade evidence for posaconazole prophylaxis. The randomized control studies showed both survival and fungal infection benefit, the decreased rates of fungal infection and decreased rates of mortality in posaconazole in patients who receive posaconazole prophylaxis, either MAL induction chemotherapy or high-dose chemotherapy for MDS. Also, the randomized control study showed the effectiveness of posaconazole prophylaxis in allogeneic transplant patients with GVHD. We have the fluconazole as the other prophylactic agent. Prophylaxis fluconazole is most useful in allogeneic transplant patients during the pre-engraftment phase. If it is used with a protective environment, also with a early diagnostic tools such as galactoman monitoring, it can be very useful to prevent fungal infections in allogeneic transplant patients. Unfortunately, there is no high-grade evidence for other hematologic malignancy patients regarding antifungal prophylaxis. The EMBIGARD study, which compared the posomal amphotericin B with standard care for the prophylaxis for antifungal prophylaxis in AR patients, was not able to show the superiority of the posomal amphotericin B. We also have micofungin as the prophylaxis, but based on the meta-analysis, it has the same effectivity with fluconazole. So we have a big group of patients with high risk for invasive fungal infections, but unfortunately, we have limited evidence except posaconazole prophylaxis for AML, MDS, and allogeneic transplant patients. And this was a real-life experience from our country. It was a prospective observation study including 18 centers, also my hospital. We prospectively observed 115 AML patients who received induction chemotherapy under posaconazole prophylaxis. The median duration of neutropenia for those patients was long as 26 days, and 35.7% of the patients received induction chemotherapy while there was a construction around the world. The success rate was 66.1, which was very similar, published from different countries as real-life experiences. And when we check the mortality rates at 12 weeks, in patients whom prophylaxis failed, the mortality rate was nearly 10 times higher when we compared with patients in whom prophylaxis was successful. So posaconazole prophylaxis has been standard care for our centers also. And this is our prophylaxis algorithm. As I told before, AML induction, high-dose chemotherapy, MDS, and allogeneic transplant patients with GVHD receive post-procainazole prophylaxis. The other patients whose expected duration of neutropenia is longer than 7 days, or which have grade 3, grade 4 mucositis, receive fluconazole prophylaxis with twice-weekly galactomannan monitoring. Also, if the patient experienced an invasive mold disease during the previous chemotherapy cycles, these patients also receive antifungal prophylaxis with the agent who cured the disease during the previous attack. Then the other stage is the empirical treatment. Empirical treatment comes from the 1980s. The physicians observed several patients who doesn't have any fungal infection-related clinical finding, but during their autopsies, they discovered deep-seated fungal infections. So there were some small randomized control studies. If the patient has fever, fever and neutropenia lasting long than 3 or 4 days under broad-spectrum antibiotics, one group received antifungals, the others received standard care, and there was a survival benefit for antifungal treatment. So giving antifungal treatment for patients who are neutropenic, had prolonged fever under broad-spectrum antibacterial treatment, and no radiological or microbiological evidence of fungal infections has become standard care in many of the hematology settings. However, these randomized studies were performed at the beginning of 1980s. So now we have mold active prophylaxis. We have better diagnostic tools that can diagnose fungal infections easier than the previous days. So the cost of the empirical treatment, antifungal resistance, and drug side effects come important questions in the hematology settings. As ID physicians, of course, we want to prove the infection by radiologically and microbiologically, but usually it is very different to do this in neutropenic hematology patients. If you wait too much, this kind of delay can increase the mortality rates in neutropenic patients. So diagnostic-driven approach, depending on the positive biomarker clinical findings or radiological markers, has become an important tool for the treatment of as an antifungal treatment strategy in neutropenic patients. There were many studies about the comparison of preemptive approach versus empirical approach, which started with feasibility studies, then comparative studies. And this was the most recent study which compared the empirical approach with preemptive approach. This was a URTC study from 15 sites in 6 European countries. 549 patients were included in the study. 8% were AML MDS patients receiving high-dose chemotherapy. All patients received fluconazole prophylaxis. At the primary endpoint was overall survival at 42 days after randomization. The first arm received empirical caspofungin just based on prolonged fever under broad-spectrum antibacterial treatment, and the other group received caspofungin if there's a sign of fungal infection based on radiology or microbiology. As expected, the usage ratio of caspofungin was higher in the empirical arm, but overall survival and invasive fungal diseases rates were very similar in both arms. And as the most recent study just published June 2022, diagnostic-driven approach seems to be very safe, even in patients receiving high-dose chemotherapy as high as defined high-risk patients. So in our hospital, if the patient has a fever longer than 72 hours under break-spectrum antibacterial therapy and no obvious source of infection, we request thorax and paranasal CT. If we have any finding that suggests invasive fungal infection, we try to do our best to diagnose the patient, diagnose the etiological agent. We perform fiber optic bronchoscopy or paranasal sinus examination and get samples for microbiology and pathology laboratories and start treatment as soon as possible. Then a final decision comes with the microbiological test results. If the CT is normal, we check the clinical status. If the patient has severe sepsis or increasing CRP, which can also be a result of the fungemia, we first escalate the antibacterial treatment based on the risk antibacterial risk situation, then start empirical antifungal treatment. If the patient is stable, we try to close the follow-up to patient by daily rounds and re-evaluate for antifungal treatment if we have any signs of fungal infection or if the patient is deteriorating, particularly without any systemic antifungal prophylaxis, we start antifungal treatment as soon as possible. Our approach mostly depends on the clinical situation and as well as radiological findings. This was the recent URTC guideline to interpret the radiological findings for invasive aspergillosis and mucormycosis. The early sign of both pulmonary aspergillosis and pulmonary mucormycosis is nodule with or without a halo. Of course, reverse halo sign is very helpful to diagnose pulmonary mucormycosis, but it is not easy to differentiate invasive pulmonary aspergillosis from pulmonary mucormycosis based on the radiologic findings. So we need something more. This is the epidemiology which can help us to decide on our antifungal treatment strategy. We have an expert mycology laboratory at our hospital, and these are the findings of the last 11 years. Aspergillus fumigatus was the most common mold that was isolated from clinical samples. And after 2014, the number of the patients with Aspergillus flavus and Aspergillus terroris started to increase. We had a stable rate of mucorales, but the increase in the Aspergillus fumigatus and Aspergillus flavus and Aspergillus terroris is particularly important because some subspecies of Aspergillus flavus can be intrinsically resistant to liposomal amphotericin B. Also, Aspergillus terroris is resistant to amphotericin B. So this was an important epidemiologic finding for our decisions. And when we check our azole resistance, we had a very, very low rate of vulcanazole resistance, both in our environmental samples as well as in our clinical samples. So it doesn't seem that azole resistance, which is a very common and big problem in certain parts of the world, is a problem for our center. Also, a multi-center study from Turkey showed very low resistant rates for azoles for nearly 21 centers. So if the radiology suggests us invasive fungal infection with a nodule with a halo cavitation or air crescent sign, we assume these patients as invasive aspergillosis. If galactomannan is positive, it is very helpful. But when we check the literature, re-evaluation of the Herberg study, which compared the voriconazole with conventional amphotericin B, the re-evaluation based on the URTC 2008 criteria showed that voriconazole is beneficial not only for the patients who has macrobiological clues for invasive aspergillosis. Voriconazole was superior than conventional amphotericin B in patients who had only the radiological findings. So we can accept these patients as aspergillosis. Then we change the type, then we check the type of the prophylaxis. If the patient receives fluconazole prophylaxis or no prophylaxis, our first choice is voriconazole. The alternative is the liposomal amphotericin B. And if the patient receives posaconazole prophylaxis, we check about the bioavailability and duration of the antifungal prophylaxis. If the patient is non-compliant or there are some problems that affects the bioavailability significantly, such as vomiting, diarrhea, or severe mucositis, or the patient is receiving antifungal prophylaxis just 3 or 4 days, we know that the steady state requires steady state for posaconazole requires 7 days. We think that those patients were not exposed to azoles appropriately. So our first line choice is also voriconazole in these patients. But if we don't have any concern about the bioavailability and the patient receive prophylaxis more than 7 days, our first line treatment is the liposomal amphotericin B. Here a question is rising about if we can treat the breakthrough invasive aspergillosis which developed under posaconazole prophylaxis by another azole. If we check the guidelines, they recommend to switch the drug group, but they say that there is no comparative study and there is no too much experience about this issue. So this approach is based on the recommendations of experts. If we check the literature, there are published case series which show no difference in the antifungal response and survival regarding the drug group switch. Also successful results by switching from voriconazole to posaconazole or from posaconazole to voriconazole has been reported. And a German study showed that the success was similar either by group switching or taking measures to increase the bioavailability of the posaconazole alone. And when we check our local results, nearly 70% of the patients were on the posaconazole prophylaxis when there was a suspicion of invasive aspergillosis, and we didn't see a significant difference for the response rates of liposomal amphotericin B and voriconazole. So we are still using voriconazole for patients who have suspicion of invasive aspergillosis under posaconazole prophylaxis if we have a concern about the exposure of the drug. Of course, the only problem is not the drug resistance for voriconazole treatment. pharmacokinetics, non-linear pharmacokinetics of voriconazole is important. So therapeutic drug monitoring can be very helpful. We have access to voriconazole TDM for nearly 2.5 years. This was the first year results, and we had a 10% of patients who had subtherapeutic levels. We need to be careful about the side effects, but it seems that we have our patients have good levels of voriconazole to treat the invasive aspergillosis, and availability of TDM increased our use of oral voriconazole, which means decreasing the cost of the antifungal treatment. Also, it decreased the rate of switching to other antifungal drugs. Previously, when we have LFTs rising, rash, something like that, which can be attributed to voriconazole, we needed to change it because we didn't have the levels to see if there's a healing. But now we have the levels. We don't need to change the drugs empirically based on just suspicions. The other problem for azole treatment and azole prophylaxis is drug-drug interactions. Careful monitorization is very important, and particularly for new leukemia drugs, midostaurin and venetoclax. They are very effective against leukemia, but midostaurin should not be used with azoles, and for venetoclax, either venetoclax dose should be reduced. If this is not possible, it should not be used by azoles because azoles increase the serum levels of midostaurin and venetoclax, which increase the hematological toxicity. Having a clinical pharmacist in your team is very important, and this study showed us that having a clinical pharmacist significantly decreased the potential drug-drug interactions in our patients. Here, I have to point out that if we have radiological findings that suggest mucormycosis, regardless of antifungal prophylaxis, our first choice is liposomal amphotericin B. Based on the microbiological results, we can re-evaluate our treatment. And having a local guideline is a big advantage at your hospital, but having it doesn't mean that it is working. So we have performed a study for investigating our compliance to our guidelines, which usually based on the international guidelines. And we had 3 stages for this study. The first stage was an observation. First, we observed what we are doing. At the second stage, we shared our observations. We gave feedback regularly and continued observations. And at the last stage, a clinical pharmacist was in charge to give recommendations after discussing the recommendations by an ID physician who is not in charge for this particular patient. So this we had a improvement for the full guidelines compliance. Initially, we had a good compliance for indication. It is as expected because systemic antifungal drugs can be only prescribed by the ID physicians in our hospital as well as in all country. But we also had an improvement at this stage. Our drug choice for right indication was also favorable. We had a significant improvement even in an area where we were successful. One of the most important improvements for the dosage, particularly important for the voriconazole, and we have a significant improvement for the duration of the neutropenia. So giving feedback seems to be very important to improve the compliance, even for your local guidelines at your hospital. Antifungal treatment is a growing area. As I can remember, when I used to search the terms antifungal treatment strategies in neutropenic patients, I have seen nearly 900 publications in the PubMed. So none of us are superheroes. Teamwork can significantly improve our practice. I think the hematologist and oncologist should be the team leader for those teams, and ID physicians should be just behind of them with radiology, mycology, clinical pharmacy, pulmonary medicine, and intensivists. And this group study will let us to develop new institutional policies when there is a change in the epidemiology, laboratory logistics, and drug supplies. Also, this kind of teamworks enable us for individual case-based discussions, which I believe very important for this kind of vulnerable patients. And I want to say goodbye with my view, a night view from my hospital. Thank you very much for your attention.
And for Dr. Naseem's talk, and hopefully we'll have you back online after that. So I would like to invite Dr. Naseem Salahuddin now. She is a professor of infectious diseases at the Indus Hospital, Karachi, and she will be speaking to us about drug-resistant tuberculosis.
Light on.
Pointer.
Okay, first of all, thank you very much for inviting me to this very prestigious conference of the Shaukat Khanum. And I want to thank Dr. Azra and Sumaya for inviting me here, getting me here. I love Lahore, and that's why I'm here. Thank you. So don't even try to read this slide. But the reason I brought it out is to tell you that, you know, for many decades, you and I, all of us have been treating drug-sensitive TB with the conventional 4 drugs, HREZ, and feeling very happy when the last smear and culture is negative. And so, you know, that has been going on for decades. But back in 1971, this was the first report that came out in 1986. But in 71, it happened that there was a patient in Texas who just would not get better from his conventional first-line drugs. And he was always defaulting on his drugs and then taking it intermittently. And then at the end of it, after when he was pretty terminal by the time, because the treatment wasn't getting successful. So they found out that he had multi-drug resistant TB, in which, of course, the 2 drugs, important drugs, INH and rifampicin, were resistant. Subsequently, they found more patients in California and Pennsylvania, and then slowly and slowly, more and more drug-resistant TB was being reported out. So that was the first time in 1971. at that time, when they found that there's not much to be done, that there were no new drugs, so they said only, there's no point in trying to treat drug-resistant TB because there are no new drugs and poor countries cannot afford it. So just let them go. Then they said, okay, then just treat those on the basis of expert advice, opinion, treatment based on observation only on the data, because the data was very insufficient. They were coming in from the rest of the world, from poorer countries where there was more and more TB and more drug resistance. So slowly then in 2002, they realized, WHO realized that this is a real problem and there should be something done to find out how to collect data and how to treat drug-resistant TB. So all these years, people were treating and not realizing that the success rate was not really that high. They were coming back. Have you ever seen recommendations? About 12 of them coming out in 2011, and probably another one in the pipeline. Every year, every 2 years, there was, or sometimes even twice, in 2000, there were guidelines for management of TB, of MDR TB, because nobody really knew how to do that. And this is how most of TB would look like by the time they came to our clinic with just destroyed lung tissue. We sort of had a parallel, the same kind of an experience at the Indus Hospital in 2007-8 when we started the programmatic management for drug-resistant TB. And we gradually became more and more understanding how to do it. And over here, one day I took the patient's medicine. मैंने कहा बताओ कितनी दवाइयाँ हैं? And I don't want you to count, but I counted, there were 31 drugs, 31 pills every single day, 31 pills just for MDR TB, and probably more for symptomatic relief like GI upset or diarrhea or whatever. And one injection intramuscular every single day for until they were negative for 6 months after the last culture. So this was a horrible thing, and most people, of course, suffered with their kidneys and their ears. और हम उनको कहते थे कान चाहिए या जान चाहिए, and most of them wanted their jaan, some didn't want their kaan. It was horrible. So this went on for more than a decade, and we were just treating them for whatever we had. We were approved we were funded by the Global Fund, and the drugs were WHO pre-qualified after 2009-10, thereabouts. And really, why do we have drug-resistant TB? Basically, it's because the cavities have khaiyan bani hoti hai, and each ml of sputum, if the patient coughs up, has more than 10 to the power of 8. That is about more than 10 million MTB bugs per ml of sputum. And they're kind of dividing all the time. They're quite strong. And if you keep giving them the first line drugs and low dosage or inadequate levels in the cavities, and if the cavities are thick walled, then they penetrate even less. So gradually they acquire, as they multiply, they acquire resistant mutations. And actually the TB mutations are not very rapid. They're due to chromosomal mutations, and they occur as independent events very slowly to the effect that 10 to the power minus 4, they multiply very, very slowly. There is, and you all know microbiology, how Staph aureus and gram negatives, they multiply and they pass on their drug-resistant genes through plasmids horizontally. But these guys don't do that. They don't pass on drug resistance. Not the same with the bacteria do. This is chromosomal, so it goes down into generations. And you all know that the resistance for rifampicin is on the RPO gene, and resistance for INH is on CATG and INHA. CATG is the bad one, and INHA is bad, but not terribly bad gene, and you can still have partial resistance, and you can still use high dose INH if you have the INH-A gene. So this is the bad one, this is the bad one, and this is what MDR is all about. Once a patient has acquired drug resistance, the same strain can be passed on to close contacts. A person who first acquires the bug from somebody else, that is primary drug resistance, or if they have been on low dose first-line drugs, then they slowly develop resistance while on treatment, and that is the secondary drug resistance. So you can just get brand new from somebody else, primary, or develop it in vivo as a secondary resistance. And of course, I think you know everything, so I'm not going to repeat, but basically MDR is RR, which means resistant to both H and R. Monodrug, when it's resistant to any one antimicrobial, but not to both. Polydrug, to more than one first-line drug, that is either H or R, but not to both, plus any other drug. It could be a fluoroquinolone, could be a pyrazinamide, a ethambutol, whichever. So that's poly. And pre-XDR is something we don't like. It's resistant to fluoroquinolone and any second-line injectable, but not together. But the one we are very frightened of, jo sabse bura se bura is XDR, resistance to everything, including bedaquiline, including fluoroquinolone and the injectables. So XDR is the one that you hope you will never see, but we see that all the time. You all know about the diagnostics. I want to make a point here that MDR TB is a lab diagnosis. It is not a clinical diagnosis. It is made in the lab. The TB strain should be tested for susceptibility and the treatment planned according to the drug sensitivity pattern and the effectiveness of the drugs. One exception is that if there has been a very close contact of an MDR patient, then the other person who is the secondary, after the index patient, may be treated with the same drugs that the index patient has been treated with for MDR. So that is one exception, but otherwise don't say, okay, I've been giving the first-line drugs for 9 months, 12 months, or 6, 8, 9 months, but the patient is not getting better. Therefore, it must be MDR. No, look for other reasons also, absorption, defaulting, etc., quality of the drug, and so on. But you must have a culture. Exceptional cases we may consider, but don't make that as a habit, which a lot of people tend to do that. कि अब ये दवा ठीक नहीं हो रही, तो let's go to the second-line drugs. Not allowed. I'm not going to talk about the smear because really that is no longer advised on its own. We go straight to the gene expert, and you all know the use of it. It detects the MTB and the RPO gene, very quick turnaround time. And gene experts have been modified over years to include the ultra gene expert, which is very sensitive, but not necessarily very specific. It is so sensitive, it can pick up as few as only 13 AFB bacteria. And whereas a smear would take what? A few hundred, a few thousand to be visible under the microscope. So here you have only 13 danas, and you can pick up. And then you have also the second line gene expert, which will pick up H, R, and fluoroquinolones. Yeah. So that is another improvement. Phenotypic, which is something that Dr. Altaf, Sumaya would be and microbiologists are very familiar with. I won't go into that, except to tell you that the turnaround time is so late, 6 to 8 weeks before you get the complete result, that you have to make a quick decision sometimes. You can't wait 2 months or 8 weeks, 2 months before you decide what to do with the patient's MDR. So there's another test, which is the line probe assay, and it is very rapid. It can tell you the genes of H, R, mutations of H, R, fluoroquinolones. And the second line LPA will also tell you about cycloserine and amikacin, of course, fluoroquinolones. So you get a complete report within, as much as your turnaround time is about 48 to 72 hours. So 2 or 3 days, you get the full answer, and you know how to start, what to start the patient with. Only problem, of course, is that it is an expensive test, but we, as a program, we have it at the Indus Hospital and we're making full use of it. I think things will change now. You may not even need to do the LPA anymore if you have the second line or the XDR gene expert. So that will tell you that will shorten your time again to a couple of hours. So things are really improving in terms of diagnostics, but you need the money for it. This was same thing. Whole genome sequencing, this is another step up for epidemiologists, but not really, you don't need it for your diagnosis. Now, to come to the 2020 updated WHO consolidated guidelines on TB, and this is where I want to put all the emphasis. As I told you, many different guidelines have come over the years, because this is not a static disease, it is a moving target. MTB is a moving target. It changes its chromosomes, its mutation from time to time. And even people as hosts, we also, this is a disease of the poor people, of malnourished people who live in crowded places, who live in high density areas. So we are seeing more and more of MDR TB or DRTB than ever before. People live in crowded homes, sometimes 8, 10 people sleep in a room 1/4 the size of this room, and they breathe the same air, so they're going to catch the disease sooner or later. So this is why there's an upsurge of MDR in our population. We used to be about 5% about 10 years ago. Now we have escalated to 10%. 10% of our TB is now MDR. This is really a frightening situation, and it's because of the overpopulation, because of poverty, because of malnutrition, so on. So things have changed, and now the 2020 guidelines, there are 4 major changes and some minor changes. The major changes are, number 1, for isoniazid resistant TB, rifampicin susceptible, H resistant, which means this is a mono H resistant TB. I think that is one place. Then we have for the usual MDR, which is H and R resistant, you have 2 recommendations, either a shorter bedaquiline containing regimen, or you have the longer regimen. And I'll talk about that in a little bit. And then there is addition of pretomanid, and that was in the BPAL trial, and we'll talk about that also. So there are these 4 things. One is for H resistance, these 2 for MDR, and this one is the BPAL, which is for XDR or totally resistant or failed treatment, and we'll do that. And then there are a few other smaller changes which tell you that it is compulsory, is mandatory that you monitor these patients' responses using culture, that starting antiretroviral therapy, patients on second-line drugs, there are certain recommendations, surgery for these patients, care and prolonged support for patients with MDR. So when you look at all these things, the 4 major, of course, you will understand, but the other changes, I don't think you can do them in a private setting. You really cannot monitor them that quickly, but you can do it only if you have a proper program. So this is what programmatic management of drug-resistant TB is, PMDT we call it. And we have a very strong one at the Indus, and now it is also spread to many other centers in Sindh and Punjab and others. To familiarize you with the drugs, there are 3 new drugs since 2015, and now they've been released lately: bedaquiline, delamanid, pretomanid. And old repurposed drugs, and you all know these names, levoflox and moxie, the quinolones, linezolid, clofazimine. You remember clofazimine for leprosy? We use that. You don't see much leprosy, but it's been used. And imipenem cilastatin. So these are the repurposed old drugs, and these are the 3 new drugs that we will be talking about. I like this slide very much because ek to rang bade achhe hain, but I think it also explains a lot of things. We used to have different classification of second line drugs. But now in the late 20s, 18, 19, things have changed. They're grouped according to A, B, and C, depending upon their quality and their efficacy. So in group A, you have the 2 fluoroquinolones, levo and moxiflox. They both are excellent in efficacy. They both are safe, although for moxie, they say that the QT prolongation, there is there's occasional QT prolongation, but people use it all around for respiratory tract infections and sinusitis and so on. But really is a very minimal chance unless if you combine with a lot of other drugs that are causing QT prolongation. But so it's very good, very safe, I would say. Likelihood of drug resistance, not really very much. So it is still based, these are excellent. In fact, if you treat your drug sensitive TB with fluoroquinolone, with moxie, the bacterial load will reduce very quickly. We're not recommending that now, but this is how sensitive so far MTB is to moxiflox. I'm not recommending it, but that's just by the way, it is very effective. And its overall rating is excellent for both fluoroquinolones, excellent so far. Levo, I would not say because there is a lot of drug resistance for levo, but it varies. In Karachi, we have much less. In Hyderabad, Kotri, where the center is, there is a lot of fluoroquinolone resistance. We know that from our trial. Bedaquiline, we have plenty of experience. It's in group A, excellent efficacy, very good with QT prolongation and hepatotoxicity, they say. But really, after having used it for hundreds of patients, we have not found much problem with QT prolongation. So it's an excellent drug. Chances of drug resistance is very low, and so it is classified as excellent. Linezolid, superb. I mean, it is really a good drug. But the problem over here is it is quite toxic. And where we have used linezolid very extensively, I think about 25 to 30% of patients get neuropathy. And that neuropathy, we have to analyze our results now, later, but it's because number one, there's a lot of diabetes. Our population is malnourished, not enough vitamin B on board. So it really causes a lot of problems with neuropathy, even mild to severe. And we've had some patients who have been just having difficulty even walking on their feet because of the neuropathy. And myelosuppression. They start off with lower hemoglobin, platelets. So it's also a problem. But if you stop it early enough or reduce the dose of linezolid, then it is reversible. And we've seen that happen very luckily. But it's an excellent drug. Also, drug resistance is not very much. So overall rating is very good. If it wasn't for the toxicity, it would be one of the excellent drugs. In group B, we have 3 drugs: clofazimine, cycloserine, ethambutol, and ethionamide. These are 2 different drugs, but there are 4 actually. And good, very, yeah, okay, pretty good. Clofazimine has a disadvantage that it gives a discoloration to the skin, and young women or women don't want to look darker than they want to be. And they always complain that rang kharab ho gaya, kala ho gaya. And so sometimes you want to stop or reduce the dose to alternate days maybe. So it's a good drug. and we use it in combination. Not much chances of drug resistance. So overall, it's a good drug. Cycloserine is also good. It's bacteriostatic, but we've had problems with neuropathy, with psychosis, with seizures, and we watched them very carefully. Many times we've had to withdraw the drug completely because of psychiatric disorders, which were not there before. We've seen people, ek banda tha, he just ran out of his house and went to a qabristan and stayed there, and we had to go and find him there with the help of the family. So these drug reactions are there with cycloserine, and you want to avoid it. The thing is, when you use it, it has very good brain penetration. It goes straight up into the brain and does all that side effects, all the toxicity. But it's a good drug, and we call it FAIR. Ethambutol, ethambutol, good bacteriostatic. You're all used it quite often with your first line. Retinopathy, color blindness, that is the problem, but it's not too bad, and we use it on occasion. Delaminate is really a good drug. It is very safe, low background drug resistance, and it's a good drug. I don't know why they placed it in C group. I think it belongs either here or A or B, but it's still down there. And I think there's more competitive commercial reason, because bedaquiline came out first and they wanted to use it more and more. Delaminate came a few years later, or whatever the reason, it's still a good drug and we use it a lot. And finally, pyrazinamide, which is a companion drug, is also excellent. But the problem with hepatotoxicity, with arthropathy, but it is recommended to use it even in second line therapy. So these are the drugs that are in use. To get to the 4 major changes, tell me if I'm going over on. Time ka bataiye? 3 to 5 minutes. Oh, okay, I'll rush through it. So when you're using mono H resistance, the formula is to give 6 months of INH if you can't separate out, but add levofloxacin to that regimen. And recommendations, there's a conditional recommendation, still not very strong, but you use levoflox along with it, or moxiflox. Do not ever use streptomycin in it. And when possible, you can also try and get the LPL, line probe assay, because that will tell you whether resistance is with CAT-G or INHA. So that will help you a bit more. But if you don't have that, just use levoflox with the HREZ. Now, the short 9 to 12 months, you use only on patients where there's no other resistance. It's a straightforward HR resistance, no previous treatment with SLD, no extensive, not a very severe disease. No, it's not EPTB. It's a woman is not pregnant and not a recommend for less than 6 years. So the regimen here is 4 to 6 months of bedaquiline, quinolone, ethanolamide, ethambutol, high dose INH, clofazimine, pyrazinamide. And then for the 5 to 7, once they become negative, 5 to 7 months, you drop bedaquiline and you continue with levo or quinolone, clofaz, ethambutol, pyrazinamide. So totally you're taking 18 to 21 pills every day. Short to hai, that's nice. Sounds like 6 to 9 months. Theek ho jaoge 6 mahine ya 9 mahine mein. But it's a lot of pills to swallow. And remember, there's no linezolid in this, okay? And it's 9 to 12 months. The longer regimens can be 18 to 20 months. And who do you prescribe it for? You prescribe for pre-XDR or XDR, previously failed treatment. It's a standard regimen, individualized regimen once you have the DSTs, and there has been contact exposure. What is the formula for that? It is you take, remember I showed you the groups. So you use, if this is a brand new patient for you, you use quinolone, bedaquiline, linezolid, all 3 drugs from group A, and one more from group B. But if you don't have enough in group A, meaning if there's quinolone resistance, then take 2 of these. And if you still don't have enough, you take another one from here to make up a total of the numbers that I told you, they're long. If the regimen cannot be composed of agents from groups A and B, group C agents are added to complete it. And start with the least 4 to 5 drugs. If bedaquiline is stopped after 6 months, continue with at least 3 to 4 drugs. And the nice thing is there's only 4 to 6 pills a day as opposed to 13 pills in the previous one. So when you give it to the patient, and first we were saying, Acha, put this one in short term, put this one in long term. And then we noticed that the patients were not happy at all. In the short one, they're taking so many pills a day. In the long one, they're taking fewer pills, but for a longer time. So now what we do is when we have to make a decision, of course, not a very severe one for short term, but we ask the patient, we tell the patient, कि भाई आपकी बीमारी ऐसी है, आपको short term देंगे तो इतनी दवाइयाँ लेनी होंगी, long term के लिए कम दवाइयाँ, make a choice. So we engage the patient in the decision making and then they follow it much better. Otherwise, in the short term, they'll say, नहीं इतनी दवाइयाँ हम नहीं खा सकते, put me in the long term. Long term, ये नहीं बहुत लंबा हो गया, आप छोटे में आए. So give them a choice, explain to them right at the start. So this is what it would look like, a standard regimen, the long term. 4 drugs, 4 months of quinolone, linezolid, bedaquiline, clofaz, and then 14 months, you drop off the bedaquiline and you carry on 14 months of that. Or sometimes if you need to, if your culture has not become negative for a longer time, you may need to give 6 months of these and then 12 months of longer one, of the 6 months, meaning extend this and add 12 months of the remaining of these. Whether you choose short or the long one, you must follow the patient clinically, the weight, temperature, clinical well-being, so on, and have a monthly smear and culture to see what your follow-up is. Of course, the culture report will come back 2 months later. Their chest X-ray at least every 6 months. And if they're not responding, they're clinically not responding, or one culture has turned positive or not getting negative, remaining positive, so look for the DST again. Ask the lab. Otherwise, they'll tell you, okay, every month they'll say negative, negative, or positive, positive. But ask them for a DST. Make sure the DST has not changed its pattern. Now, there's another drug, pretomanid, which is very closely resembles delamanid. It has similar mode of action. So there was another trial with bedaquiline, pretomanid, and linezolid called the BPAL. It's still a trial. It's been recommended now, but not every place has got, not every country has been able to get the pretomanid. So we are still using the other without pretomanid. And this has been quite successful in XDR failure, XDR, MDR failure, and patients with HIV. Success rate was 90% reported in the New England Journal 2020. But when you read that article closely, you will notice that the sample size was very small and that there was so much toxicity with linezolid that they had to either discontinue or reduce the dose. So I'm not very impressed with this particular article. We'll have to wait for more evidence to come by. I mean, after all, XDR is difficult to treat. So minor changes, as I said, you must monitor them. Sputum culture, smear every month. Antiviral therapy, it's like the DS. You first treat the TB and then start the HIV ARV later. Within the first 8 weeks, it's practically the same. Surgery is recommended. Now, if you had a patient like this with a fairly decent left lung, but all this over here where there is such a high burden of TB, it's just bhara hua TB germs ke saath. So if you can delete this part surgically, that would really reduce the load and improve the survival of this patient. But who wants to cut off lungs like this? I mean, no surgeon wants to touch them. We haven't been very encouraged. And then you care and support them for ambulatory care, health education, nutrition, home-based care, all these things must be there. This is a useful slide, and I think you must make note of it because a lot of questions, I get a lot of these questions from everywhere. In TB meningitis, the good penetration is with quinolones, ethionamide, cycloserine, linezolid, imipenem, high-dose INH, and PZA. These penetrate quite well into the CSF. Poor penetration of ethambutol, PAS, and amikacin, except when the inflammation is really active there. And insufficient data for bedaquiline, delaminate, clofazimine, that they may or may not penetrate into the CSF and abscess or tuberculoma. If it's a drug resistant, you've proven it. It's difficult, but not impossible. You use the quinolones, you use cycloserine, you use linezolid, INH, PZ, all these as much as possible. I won't go into detail, but just to tell you that all the drugs have different modes of action on the mycolic synthesis or penetration of the mycolic wall. Bedaquiline, I'll just point out that it has excellent drug, but and the half-life is 5.5 months. बंद भी कर लें उसको तो 5.5 months तक you still have some bedaquiline in your system. Delaminate, again, a good drug. It's let's see, it may be combined with any of the drugs. Bedaquiline, it's a good drug. Pretomanid, I've never used it. We haven't obtained it over here. You know why it's called Pretomanid? Pretoria, capital of South Africa. It helps you remember. Pretoria, capital of South Africa. This is where the drug was first used. So Preto and manid, because I think it resembles delaminid, is the radical of that. So PA, it's a novel drug, the latest one against MDR. Some problems there with hypoglycemia, neuropathy, hepatotoxicity, but you use, the trial was in XDR and failed treatment. And I guess that's a last ditch effort, but now it is being recommended using it in the right away in the treatment of MDR. Linezolid, I won't talk much about that, but I did tell you that peripheral neuropathy, bone marrow suppression, clofaz, imipenem, silacetin. If you have an absolutely failing case, you have no other drugs to act, then put in a long line and try giving it, but to give it for 3 months to 4 months IV to a patient who's failing anyway, it's going to be a difficult task. There are many other combination trials going on. END-TB and TBQ, this is the one that I am the PI for, and it's being run in 7 countries. We've almost finished enrolling drugs, and I think we are now waiting for the follow-ups for 107 months, and then the results will be compiled, and that will take some time. But there are other trials going on at this time, the STREAM, NIX-TB, TB Practical, BPAL, OptiQ, all these are trials using different combinations of these same drugs. You just play around with the doses, combinations. Poor adherence, all these are the challenges which we all face when treating drug sensitive, even drug resistant TB more, but drug sensitive also. We find hard to chase a patient with the wakhare and what is happening, you're having side effects. So we have to do that. And if you think this is difficult, we meet every Friday for hour and a half amongst the END-TB trial group and the ID fellows and medicine fellows and some of the pulmonologists. We sit around for an hour or more and discuss difficult cases. Sometimes we find a solution, but we do it by consensus, and it's not always easy answers, especially if the patient is failing or reversal of a negative. They've been culture negative for 9 months, and then in the 10th month becomes positive. What do? I mean, you tear your hair, you say, why has that happened? So we have to reformulate the whole therapy make certain decisions. So every week we meet and discuss all these things. Thank you. Yeah.
Thank you, Dr. Naseem. We have a couple of comments and questions, so we'll just take the online questions first. So the first one is for Dr. Zaf. Dr. Zaf, since cultural and behavioral changes take time, a quick way to address IPC and antibiotic stewardship is to impose reward penalty approach. A central body like Punjab has commissioned and commission should make it mandatory for hospitals to report their antibiotic consumption and their hospital acquired infections data. Based on these, hospitals should be tracked. Unfortunately, the wish list is very long, but and we are very little to optimize this practice. So, what do you suggest?
Right. So, जिसने क्वेश्चन पूछा है उसे गवर्नमेंट के सिस्टम का नहीं पता शायद, क्योंकि इट्स नॉट दैट इजी. बहुत आसानी से रेगुलेटरी बॉडीज, हेल्थ केयर कमीशन, सिंध, पंजाब और whatever, I mean there are issues with their own guidelines. I mean they still talk about cutting needles, they still talk about taking swab of floors and roofs of operation theaters, and there are so many. They still talk about incinerators. I mean we have got shredder disinfector, they don't believe it. And whenever they come to PKLI, they want an infection control nurse to answer them. They have nowhere written there is an infection control doctor. So it doesn't exist. So उनके अपने इतने सारे issues हैं और उनको खुद समझने की जरूरत है. हेल्थ केयर कमीशन ठीक है, एक हेल्थ केयर कमीशन है जो अच्छी चीज़ है, लेकिन वो खुद अपडेटेड नहीं है. You see, डॉक्टर नसीम ने अभी लेक्चर दिया MDR टीबी पे, पता नहीं कितने hundreds of lectures होते हैं, IPC पे भी होते हैं, सब पे होते हैं. अगर आज हमारा मकसद क्या है यहाँ पे अपडेट होना, हमारे रेगुलेटरी बॉडीज खुद ही अपडेट नहीं है, हमारी मिनिस्ट्रीज खुद ही अपडेटेड नहीं है, तो आगे क्या रेगुलेटरी बॉडीज और क्या कैरेटिन स्टिक यूज करेंगे. सो दिस इज द प्रॉब्लम. ऑब्वियसली अगर ऐसा हो जाए तो बहुत अच्छी बात है, बट इट्स नॉट.
Do you have any questions from the audience?
सर कि इन्फेक्शन के लिए जीपीएस क्लिनिक पे प्रोड्यूस होते हैं फ्रॉम रिंगर लैक्टेट या ब्रेडना स्ट्रिंग और वो इनसे और जीपी क्लिनिक पे प्रिक की नीडल्स यूज करते हैं. और हम ये भी देख रहे हैं कि हॉस्पिटल्स में आजकल डेंगू की वजह से बहुत से रिंगर लैक्टेट्स लग रहे हैं. तो इसको कैसे तर्क किया जाता है और कैसे खत्म किया जाता है?
आप मुझे नीडल्स या कैनुलास की मतलब डिफाइन एंड डिस्पोजिंग कैसे करते हैं?
So करनी तो चाहिए. नीडल ऑब्वियसली ऑटो डिसेबल सिरिंजेस भी अवेलेबल है पाकिस्तान में, इट वाज लॉ, लेकिन अगेन उसकी कॉस्ट को बियर करना आसान नहीं है. दे शुड बी यूजिंग ऑटो डिसेबल सिरिंजेस और ड्रेप और उसकी चीज़ें. आई मीन अनफॉर्चुनेटली उनका कोई सिस्टम नहीं है. At least I can talk about Punjab. बहुत अच्छा सिस्टम रोबस्ट बना था to pick up waste in various hospitals, not from.
प्राइवेट हॉस्पिटल्स का कोई सिस्टम नहीं होता. प्राइवेट हॉस्पिटल्स भी है जो शानदार नहीं बने होते हैं या जो इस तरह के.
हाँ, तो वही रेगुलेटरी बॉडीज जिसकी पहले सजेशन दी गई थी, ये उनका काम है, चाहे वो प्राइवेट हो चाहे गवर्नमेंट हो, but it's not working up to the mark. It's not up to the mark. और जो छोटी क्लिनिक्स हैं वहाँ तो वेस्ट इज जस्ट गॉन विद द डोमेस्टिक वेस्ट. सो देयर इज नो सिस्टम कि वो जो छोटी क्लिनिक्स हैं वहाँ से भी उठाया जाए. सो प्रैक्टिकली इट्स नॉट हैपनिंग, लेकिन ये एक बहुत बड़ा सोर्स हो सकता है. दैट्स व्हाई यू आर आस्किंग दिस क्वेश्चन. जाहिर है इसके लिए कुछ करना चाहिए, बट अगेन द गवर्नमेंट की मशीनरी ये काम कर सकती है, कोई NGO कर सकती है.
Dr. Mason.
Dr. Mason, one question in your, can you hear? Yeah. Question is in the patients with neutropenia and X-ray findings of cavitations or abscess. And you said Aspergillus is the fungus that you most likely find. Where does this Aspergillus come from in your institution? I know it's environmental, but how is it there in your case? Is it from ventilators? Is it from the air conditioners? Or have you been able to identify that and control it?
We have experienced some outbreaks regarding to air condition systems in our hospital, but this is a very rare situation. Most of them are latent infections, which become active under high dose immunosuppressive therapy. So most of them are, we believe, they're endogenous. We have a surveillance system based on the URTC MSG criteria. If any patient who receives a diagnosis of invasive aspergillosis after hospitalization more than 7 days, based on URTC MSG criteria, we accept them as nosocomial acquired invasive aspergillosis. We have a routine surveillance for them. And we have very rare cases based on this definition. So most of them are endogenous cases who were colonized previously, then became apparent under the highly immunosuppressive therapy. But sometimes during the last 7 years, we have experienced 2 outbreaks related to our air condition systems. But we were able to realize what's happening based on our active surveillance systems. So the intervention stopped the outbreaks.
Oh, Dr. Mathan, did you see a spike in infections because of mucor in your cancer patients following after COVID came along?
We have experienced increases in for invasive aspergillosis patients after the COVID pandemic, but in our hospital, COVID-related mucormycosis has not been documented until now, but there are some centers in Turkey who has a relatively higher number of patients with COVID associated mucormycosis, but in Turkey, mostly it is as COVID aspergillosis and COVID associated pulmonary aspergillosis.
Thank you, Dr. Mathan. Dr. Naseem, there's a question for you. So in regards to multi-drug resistant TB, miracillin and delaminate have they been included for pediatric cases? And what do you think are the increasing what is the cause for increasing incidence of MDR TB in Pakistan?
Now I'll take the second question first. What is the reason for increasing MDR cases in Pakistan? I think it's overpopulation and high density population. More than the overpopulation, high density population. As I said earlier, in a room 1/3 the size of this, you may have entire family of 6-8 people sleeping in the same room, breathing the same air, or also in places of work. I've found people who are working in garment factories in maybe a very long area, poorly ventilated, and if 1 or 2 people over there, one person has TB, they're working with others in the same environment, breathing the same air, that's likely to be. Also in schools, madrasas, people living in dormitories. So this is the reason for increased reasons for TB of any kind. But MDR is because it is being transmitted there. It is being transmitted. If one person has MDR, the other contact will also get MDR, high chances. Another thing I failed to mention was that sometimes the population of bacteria, MTB in the lung is also heterogeneous. There may be a mix of drug sensitive and drug resistant TB. Luckily, the second line drugs also kill the first kill the drug-sensitive bugs. So that's a cure also. But there are times when we see if the population of the DS, drug-sensitive bugs, is more, then you may miss the drug-resistant population, and you're only focusing on the drug-sensitive, which means that the drug-resistant ones are waking up. I mean, they're proliferating. Dusra question kya tha? What was the first part?
Bedaquiline and delaminate for pediatric.
Yeah, bedaquiline and delaminate for pediatric patients. Both these drugs, while they were new on the market, they were not to be used for pediatric or below the age of 6. But then what to do when children below that age were failing second line treatment? So then a lot of trials happened in South Africa. Dr. Jennifer Furen, I heard her give a talk, very good talk on this. And then she published papers using delaminate in small children and found it was quite safe. So then now these are allowed. I mean, after all, what else can you do? You've got to try it out. And if there's no adverse event, go ahead and use it. So this was after proper trials, and it is being used in smaller children now. I think 6 months is the cutoff age, but that's how it is now. That answer my question?
My question is to Dr. Mathan. In your talk, you mentioned patients like who are on chemotherapy and they receive posaconazole prophylaxis. So 15 out of 76, I guess, was the number who developed breakthrough fungal infection. So my question is, what was the fungal isolate in those cases? Was it any different than those who were not on posaconazole prophylaxis, like mucor or? So what first question is this. And in second question, basically I work in a transplant setup, and in liver transplant mainly, people sending fungal markers like galactomannan, and many times it come back borderline positive, like if the cutoff is 0.5, then the result would be 0.6 or 0.5 something. And HRCT and CTNS is negative for any fungal infection. So what would be your take on this? Should we treat patients because they are not like neutropenic, but they are on immunosuppressants? So should we treat them with borderline positive markers with negative imaging? Thank you.
Well, unfortunately, most of our patients who have suspicion of breakthrough fungal infections under posaconazole prophylaxis does not have a bronchoscopy due to severe thrombocytopenia or severe hypoxemia. So we only have in our hands only a persistent fever, deteriorating respiratory symptoms, and a positive thoracic CT, which shows a nodule. So our usual diagnosis based on radiology. Sometimes we have positive galactomannans, which can either suggest aspergillosis or fusarium or fusarium. So definitive etiology of breakthrough fungal infections in our center is not very clear, related to low rate of sampling. But whenever we have samples, we usually have aspergillosis. The number of the cases with mucormycosis is very low in our center. But there are certain centers in Turkey that have reported mucorales under posaconazole prophylaxis. So it's a possibility, but we haven't documented yet. So usually the case is diagnosed by radiology, sometimes with by positive galactomannan, which is very rare under posaconazole prophylaxis. And the second point is the cutoff of galactomannan, I think, in liver transplant patients. So for liver transplant patients, there's not a comprehensive study about the galactomannan cutoff. We know that in non-neutropenic patients, the sensitivity of the galactomannan decreases significantly. So, for example, Kappa patients, although recent URTC categorization recommended as 1 for serum or plasma as the cutoff for galactomannan, the ISHAM recommendation gave a 0.5 as the cutoff of galactomannan for defining kappa patients. Of course, they are not diagnostic. They are for criteria for clinical and epidemiologic studies, but we usually use them both in the clinical settings. So my recommendation, if you have a positive galactomannan, like 0.5 in a hepatic transplant patient, liver transplant patient, if you don't have any suspicion of any fungal infections based on your clinical findings, also radiology findings, if the patient is getting better or doing well, there's no need for any preemptive antifungal treatment. You can check your galactomannan a second time. You can repeat the galactomannan, and based on the results, I think it is better to start with two positives in an asymptomatic patient without any definite cause of false positivity will be better. If you use beta-lactam antibiotics at the same time, you have to be careful about the false positivities. Although the original branch of piperacillin tazobactam with ETA has no relation between false positivity of galactomannan, there are many generic brands, so they can easily cause false positivity. I will suggest to getting the sample time by checking the antibiotic infusion time. So only one positive galactomannan is 0.6 in an asymptomatic liver transplant patient does not require any emergent antifungal treatment, I guess.
Hello, Assalamu alaikum. Sir, how can we control hospital-acquired infections like patients on ventilators, on CPAP, BiPAP, and on high-flow nasal cannulas? Like, how can we control and prevent the cross-infection on ventilators, on ICUs, and in medical wards? The patients उनमें fungal infection कैसे control कर सकते हैं? और जो CPAP, BiPAP और जो high-flow nasal cannulas पे होते हैं patients.
Is that question for Dr. Altaf?
Not for me.
Or is that for Dr. Mehta?
Dr. Mehta said, Dr. Mehta said.
Before Dr. Mehta answers that, we have the SN Rashid Memorial session starting in 3 minutes. So I would really suggest for others to make it to that. Then I'll be concluding the session after this question. So yes, Dr. Mehta, would you like to answer that question?
I'm very sorry, but I cannot able to understand or just
How can we?
question clearly.
Sir, how can we control the infections like on patients on high-flow nasal cannulas, on CPAP, BiPAP, in ventilators, in ICUs, and in medical wards? Like how can we prevent and control the cross infections in those wards and ventilators and ICUs?
Prevention of invasive, we are talking about the prevention of invasive fungal infections, I think.
Yes, exactly.
Well, it's a very difficult task if it's an open ICU with very different airway flowings. But we can we have experienced an outbreak during the COVID outbreak and aspergillosis outbreak in intensive care units due to the mold colonization on the ceilings. So we have to be very careful about the environment, and wearing a mask will be very helpful for the patients if they are sitting on an open ICU. And there is one study about antifungal prophylaxis for intensive care patients to prevent COVID-associated invasive aspergillosis. And posaconazole was successful to prevent invasive aspergillosis, but it was IV posaconazole, not the oral posaconazole. Posaconazole for 10 days were very successful to prevent from invasive aspergillosis. But however, the patients who received prophylaxis and who didn't receive prophylaxis didn't have a different mortality rate. So in a setting where it is difficult to control the airway, mold-active prophylaxis can be used to particularly for the patients who are receiving both high-dose steroids and tocilizumab to prevent invasive fungal infections in those kind of patients.
Thank you, Dr. Mathan. Thank you so much for taking the time out for the for the presentation and for staying back for the live question and answer session. We would really like to thank you. And with this, I'm concluding the infectious disease session, and we have the SM Memorial session starting right now. So I would request the audience to please proceed over there. Thank you. Thank you, Dr. Mathan. Thank you, Dr. Naseem.
Thank you very much for the invitation.